Childhood acute leukemia. Leukemia is defined as a group of malignant disease in which genetic abnormalities in a hemopoietic cell give rise to unregulated clone proliferation of cells. The progeny of these cells have a growth advantage over normal cellular elements because of their increased rate of proliferation and decreased rate of spontaneous apoptosis. Another deficiency, it is a malignancy of immature hemopoietic cells. The bone marrow show more than 30% blast cells. It arises initially in the bone marrow before dissemination to peripheral blood, lymph node, and other organs. Etiology. Most of cases of acute leukemia are thought to be caused by post-conception somatic mutation in lymphoid cells. However, the identification of the leukemia-specific fusion gene sequences in archived neonatal blood spots of some children who develop acute lymphocytic leukemia at later date indicates the importance of in utero event in the initiation of malignant process in some cases. The long lag period before the onset of the disease in some children, reported to be as long as 14 years, supports the concept that additional genetic modifications are required for disease expression. Genetic factor may play a role, and this is proved through increased incidence in identical twin and siblings of leukemia and increased incidence in certain genetic disorders, such as the following: Down syndrome, Fanconi anemia, Bloom syndrome, Blackfan-Diamond anemia, Schwachman-Diamond syndrome, Kostman syndrome, neurofibromatosis type 1, ataxia telangiectasia, severe combined immune deficiency, paroxysmal nocturnal hemoglobinuria, and Li-Fraumeni syndrome. Another etiological factor is environmental factor, including exposure to ionizing radiation, drugs, alkylating agent, epipodophylotoxin, and benzene. Viral infection may play a role, such as Epstein-Barr virus, as well as immune deficiency, as in hypogammaglobulinemia. The incidence is higher. Epidemiologically, it is the commonest malignancy in children, with ALL forming to AML in a ratio of 5:1. Peak age between 2 to 5 years. Older are those with AML. Male are affected more than female. The T-type is more common in boys, and the infant leukemia more common in girls. Morphologically, it can be classified into acute lymphocytic leukemia, 80%, and myeloblastic leukemia, 15 to 20%, which is characterized by the presence of ORBD. The WHO classification classify leukemia phenotypically, depending on the service marker, where ALL is classified into B, lymphocytic leukemia, previously known B-ALL or pre-B-ALL, forming 85%, and T, lymphocytic leukemia, 15%. This is a slide showing a myeloblast, which is usually larger than lymphocyte with the presence of ORBD. The oldest classification is the French-American-British FAB classification, classified leukemia into L1, L2, and L3. The L1 forming 80%, the blast is small with indistinct nucleoli and little cytoplasm. While L2, 20%, the cells are larger with apparent cytoplasm, cytoplasmic granule, irregular nuclear membrane, and prominent nucleoli. The L3, which is larger and characterized by being intensely basophilic cytoplasm, prominent nucleoli, and presence of cytoplasmic vacuoles. While the myeloid leukemia is classified into M1, which is myeloblastic, no maturation, M2, myeloblastic with some maturation, in which the ore body will become apparent. This is the ore body. The M3, which is the hypergranular promyelocytic leukemia. The M4, myelomonocytic. M5, monocytic. M6, erythroleukemia. And M7, megakaryocytic leukemia. Flow cytometry and special stain assist in identifying myeloperoxidase containing cell, such confirming both myelogenous origin of leukemia and the diagnosis. This is a special stain used in the lab to differentiate between ALL and AML. In case of the ALL, it is positive for PAS and for acid phosphatase, but it is negative for Sudan black, peroxidase, and esterase, while AML positive for all types of stain. The difference is that in PAS stain, the ALL will show coarse granules or blocks, while in the AML, it is also positive but diffuse. In the acid phosphatase, it is positive for ALL with paranuclear localization, while it is diffuse also in AML. Molecular analysis and karyotyping is very important. The presence of translocation 411, 922, and 119 in ALL carry poor prognosis, while translocation 814, 28, and 822 carry good prognosis. In AML, translocation 1617, 821, and inversion 16 carry good prognosis. The clinical feature, the early manifestation are non-specific. There is fever, anorexia, irritability, weight loss, viral upper respiratory tract infection 1 to 2 months prior to diagnosis. Bone marrow failure become more obvious with occurrence of pallor, fatigue, exercise intolerance, bruises, oral mucosal bleeding, and epistaxis with hepatomegaly and lymphadenopathy. This picture, you can see the child is pale with evidence of petechiae on the face and as well as on the abdominal wall, and abdominal distension may be due to hepatomegaly with evidence of lymphadenopathy. Bone pain and joint pain may occur in the lower extremities, which is usually severe and may awake the patient at night. There is joint swelling with or without tenderness. CNS leukemia can be presented as headache, vomiting, convulsion, cranial nerve palsy, papilledema, and retinal hemorrhage. There may be respiratory distress due to anemia or because of mediastinal mass causing airway obstruction, and this is mainly encountered in adolescents with T-cell leukemia who have a white cell count. This is a picture with a child with ALL having mediastinal mass causing superior vena cava. There is a specific sign seen in myeloid leukemia, including subcutaneous nodule or blueberry muffin node lesion, infiltration of the gingiva and gingival hypertrophy, chloroma or granulocytic sarcoma, which is an epidural and orbital location and collection seen in AML, mainly M2 with the translocation 821. DIC seen in acute promyelocytic leukemia. In all types of leukemia, CNS symptoms are seen in 5% of patients at presentation, 10 to 20% as blast in the CSF, testicular involvement seen in 20%, and ovarian involvement in 30%. The investigation, The complete blood picture reveals anemia. The white cell count may be normal, high or low, with low platelet, and the bone marrow show more than 25% being blast. LP, usually blast. If present, there is CNS leukemia. Chest X-ray is necessary to detect mediastinal mass, which indicate T-cell leukemia. Liver function, renal function, and uric acid should be done before starting therapy, and both X is done only if there is joint pain and bone pain. It will show medullary trabeculation, subperiosteal hemorrhage, and cortical defect. This is a chest X-ray of a child with mediastinal mass. Before and after treatment, it will be back to normal. Differential diagnosis, ALL, should be differentiated from ML and from other causes of marrow failure, such as aplastic anemia and myelofibrosis, infectious mononucleosis, rheumatic fever in case of bone pain and joint pain, and marrow infiltration by solid tumor, including neuroblastoma, Ewing sarcoma, rhabdomyosarcoma, and retinoblastoma. For the treatment, of course, chemotherapy is the mainstay of treatment, but before starting treatment, we should prepare the child with hydration, alkalinization, and allopurinol to prevent tumor lysis syndrome. Then we have the induction phase lasts for 4 weeks, followed by intensification phase to overcome the remaining malignant cell, the CNS prophylaxis by craniospinal irradiation, which is used previously. Now it is only indicated in those with CNS disease at presentation. Children who are less than 2 years should not receive radiotherapy, and CNS prophylaxis nowadays is done by intrathecal chemotherapy, methotrexate, and cytosol. Testicular radiation applied for children with testicular disease and those who receive cranial irradiation. The maintenance phase lasts for 2 to 3 years. Philadelphia chromosome positive ALL with the translocation 922 has been dramatically changed by the use of imatinib, which is an agent specifically designated to inhibit BCR-ABL kinase resulting from the translocation. With this approach, the event-free survival improved from 30 to 70%. In acute promyelocytic leukemia M3, the prognosis and the treatment outcome is improved by using retinoic acid receptor that mainly the ATRA, which act on the junction between the translocation 15 and 17 here, combined with anthracycline and cytarabine. Supportive treatment is very important, giving blood and platelet when needed for anemia and bleeding tendency, antibiotic when there is febrile neutropenia to overcome gram-negative and gram-positive organism, as well as antifungal and antiviral, prevention of pneumocystis carini infection by the administration of trimethoprim sulfamethoxazole, and the use of granulocyte colony stimulating factor if there is chemotherapy-induced neutropenia. Stem cell transplantation is indicated in ALL if there is cytogenic abnormality with poor prognosis, such as translocation 922, translocation 411, and after relapse, while in AML it is indicated in the presence of monosomy 5 and 7, 5q- and 11q23 abnormality. What is the tumor lysis syndrome? It occurs in ALL with induction phase. There will be destruction of malignant cell and normal cell with release of intracellular content causing hyperkalemia, hyperphosphatemia, hyponatremia, hypocalcemia, and high uric acid, which deposits in the renal tubule causing acute renal failure, oliguria, and anuria. This can be prevented by hydration, alkalinization, and the use of allopurinol. This slide shows linear streaks هذا السهم of uric acid precipitation in the renal medulla. Another problem can be seen in leukemia, which is life-threatening, is the leukostasis. It is mainly seen in AML. Because the myeloblasts are larger than the lymphoblasts, they will increase the blood viscosity and include small cerebral vessels, causing cerebral thrombosis and hemorrhage, and even death before induction. Relapse sometimes occur in the bone marrow. Sometimes there is CNS relapse, but now it is decreased to 5% with the preventive measures of CNS therapy, and testicular relapse occur in less than 2% of boys with AML. Concerning the prognosis, poor prognosis seen in high-risk children. They are children who are less than 1 year or more than 10 years of age, male sex, black race, when there is white cell count very high, more than 50,000 at diagnosis, CNS leukemia at diagnosis, presence of mediastinal mass, T-cell leukemia or L3, chromosomal abnormality including translocation 411, 922, and 119, and failure to achieve remission day 28. While good prognosis seen with a standard risk when the child is usually aged 1 to 10 years, female sex, white cell count at diagnosis less than 50,000, no CNS leukemia or mediastinal mass at diagnosis, the type of leukemia pre-B اللي هي common ALL, complete remission day 28, no testicular mass at diagnosis, and presence of TEL-ML1 gene. In AML, poor prognosis when the white cell count is high, more than 100,000 because of leukostasis, low platelet count at diagnosis less than 25,000, presence of chromosomal abnormalities as deletion 5 and 7, and failure to achieve remission after